Hi, everyone. Welcome to our event, Flipping the Script, a teach-in for healthcare workers on homelessness and aging. Next slide, please. Just some housekeeping rules are, since this is a webinar, everyone will be on mute with videos off. The chat is disabled. To enable or disable subtitles, please select live transcript at the bottom of the screen. Please use the Q&A box, not the chat box, to submit questions for the panelists, and you can upvote other attendee questions and also make comments. We will try to answer as many questions as we can during the Q&A portion, and a recording will be made available at a later date. Next slide, please. Please feel free to join the conversation on Twitter using the hashtag #FlippingTheScript. And today's Twitter moderators will be Dr. Kelly Doran at KM Doran and Dr. Giselle Routhier at Giselle_Ashley. And just to give some background on our event, the event is co-sponsored by the NYU School of Medicine's Health by Housing Lab, the Health and Housing Consortium, and the Corporation for Supportive Housing. So today we have an amazing panel lined up, and the event will be moderated by Dr. Lee Isaacson. Lee earned his medical degree at the University of Cincinnati College of Medicine and completed his residency training in family medicine at Albert Einstein College of Medicine, Montefiore Medical Center. He spent years working in homeless healthcare, more recently at Safe Havens and on street medicine teams in Brooklyn. And prior to being a physician, he worked as a street outreach provider. Today's panelists are Danielle Broom, who is 64 and is a former resident of the Boston Road Breaking Ground supportive housing site. We also have Scott Burton, who is 64 years old and currently resides at the Bridge Supportive Housing Organization in Brooklyn. We also have Deborah Gorkowski, who is 60 years old and a resident at Susan's Place Shelter for Women. We also have James Litgett, who is 65 years old and is a resident at Wishfifth Supportive Housing. And lastly, we also have Lockett Schroeder, who is 6 years old and resides at Valley Lodge Shelter. Thank you, everyone, and I will now turn it over to our moderator, Lee.
Hi, good afternoon, everybody. Thanks for joining. I'm just going to sort of frame our discussion, and then we'll get into the session. So the population of older adults experiencing homelessness in the US is growing. Adults over the age of 50 now make up at least 30% of the nation's unhoused population. And some estimates show that by 2050, there'll be over 95,000 older adults experiencing homelessness in the country. The city also tracks these data and reports that the number of homeless individuals in the shelter system above the age of 55 has increased by about 250% from 2004 to 2017. And the number of homeless individuals aged above 65 has increased over 300% over the same time period. Like many aspects of homelessness, there's no single answer to explain why these numbers are progressing the way they are. However, research has shown consistently that there is a cohort effect from the second half of the baby boom that's driving a big segment of the population. For more information of that, the Health by Housing Lab's own Kelly Doran helped author a report looking at older adult populations experiencing homelessness in New York, Los Angeles, and Boston in conjunction with the city. But I sort of find it helpful to think about older adults and homelessness in two general ways. There's the group who are either on the street or in the shelter system who are kind of like aging in place. And they make up kind of a chunk of that cohort effect of the second half of the baby boom that's been increased risk for homelessness. And then there's another group of people who find themselves newly homeless, either as older adults or in middle age. And that's kind of often largely driven by changes in financial and social situations. So before we can even kind of talk about things we need to be doing to address some of these issues, we kind of just need to sort of frame any kind of like policy discussion by kind of centering it on people's lived experience. And so the best way to learn kind of how to talk about things is really to hear from those people who have lived these who have lived expertise. So today we're excuse me. Today we're going to do excuse me. Today we're going to do just that. We're going to hear from older adults about their experiences in housing and in healthcare. And today, as ever, language and word choices matter. I would invite everyone, but especially learners and trainees, to please pay attention to the word choices that our panelists use. Thank you very much for attending. And with no further ado, we'll kind of get into the next part of the session, which will be our moderated discussion. Okay, so this question is kind of for anyone, but what have been an experience that you've had navigating the homeless system as an older adult? Can you mention some of the challenges you faced, and maybe as part of that process, what services you wished had existed at that time of that challenge?
Hi, my name is Deborah, and the thing about it is that right now, I feel like DHS is actually mixing people together rather than trying to separate them. Like, for instance, the medical versus the mental. I'm in a MICA shelter, and the problem with that is that I don't have any kind of mental problems. I have plenty of medical problems. And it becomes stressful, especially in my case that I just started college to get my certificate as a medical coder. I'm up against a lot of different personalities, and a lot of problems occur in the system here because of that.
Thank you for sharing that.
Mm-hmm.
Anybody else want to jump in with some sort of just general experiences that they've had?
Yes. My experience are what I think for this time around. There should be more shelters that are more diverse in terms of age options for the LGBTQ community. And for shelters to have a more active reach out for people living on the streets and have people knowing that they're safer these times, because people be more likely to go to shelters. I think that's the biggest concern, is the safety issue. You know, I know that when I was in the shelter, my biggest issue was safety, and I learned that, you know, it became safe because I became more comfortable. And so those are the two biggest issues that I think that need to be addressed more. Thank you.
Thank you.
How you doing? Good afternoon. I'm Daniel Broom. I'd like to chime in behind Ms. Deborah and Mr. Scott. Living in the Boston Road residence, haven't gotten off the street. And as they say, listen, the safety issue is really, come on, you got old, elderly, fragile people, and you have these extremely MICA people. And they don't have no set person who they want to go off on when they have their moment. So, I mean, instead of having some kind of way to separate the population, I mean, to give the older people a little more sense of security and safety, you know, they just, you know, it doesn't make a difference what your mental capability or your physical your abilities. They just put you all in one bucket, you know. So
just to jump in for a second, as you all are answering some of this question, if you could like tell us a little bit about your own sort of, you know, like biographical experience, as you know, like you're identifying, you know, like it's wonderful that you've identified that the ways in which sort of the shelters are mixed and, or, between older adults and people experiencing mental health concerns. But if you, to tell, like, feel free to like include some of the details of your own lives, as you've worked with these supportive housing programs or in shelters or on the street.
Well, okay.
Go ahead.
Okay, well, for me, what it is that, like, for instance, I have the city FEPS, okay? I also have the 2010E General Pop. And in New York City, I've tried so many times to get places. It's really overboard what they're doing. New York City, the rents are so high. And a lot of landlords, they cannot turn down a city FEPS if they have so many units. But here's the thing, they'll come out and they'll say, oh, we do accept city FEPS, but we have no apartments for that right now. And it gets pushed off to the sidelines, The only thing that I'm keeping in mind right now, which I'm very happy with, is the fact that a program came into here and it lifted me up to get back into schooling. And hopefully when I get my certificate, if I can't get a way out with the voucher, maybe I can find a way out on my own. But the system is really designed to where you're kind of stuck in some situations. And I don't blame the workers because like the housing assistants, the housing specialists, they are overwhelmed. Like in this place, you got like 2 of them to 200 clients. Based on that, it's hard for them to deal with situations and getting housing. So I feel that it has to change. And the other part is that when they say low income, a lot of places you look for low income, it's not low income. They're talking about things that are way out of my league and a lot of other people's leagues as far as paying rent. That you can't even get an application because they want X amount of dollars over what you can do.
Yeah, I think those are really crucial pieces of that. And I think you're highlighting the fact that, even when you got, a city FEPS voucher and are working with programs, that it's not enough to have, to sort of have qualified for something, right? It needs to then be available to be connected to an actual, piece of housing on the other end of that.
Yeah, definitely.
Okay, I have a comment. I believe that it's best and in your own best interest to, because I was moved around. I was 4 years in the shelter system, and they would move me around to 3 different shelters. It's like once you get comfortable, it's like then it's pack up and move. But you have to still be able to navigate within each system that you're in. You must navigate, what this system is good at, what they're not good at, stuff like that, for your own best interest. And to stay on the housing managers and stuff like that, so you can expedite the situation for yourself. I don't believe in sitting back waiting for it to happen. I like to give a little push here and there. and yeah, and it makes me feel like I'm doing something, even if I'm only upsetting the person. But that's what you have to do. And you should know each system how it is and how it is not, what is good at, what is not good at. Like so, the 3 different places where I said I was at, I knew which one was good at what. And these are things you have to know because you are there. You are there now. When I'm somewhere, I take operational control, let's say. I know what they're good at. I know who's good at what. I know who to go to.
Yeah.
All those kind of things. I don't leave anything to chance, let's say. I take an active participation in my life.
Yeah. Chaplain,
Okay.
what piece of advice would,
For 1 second.
go ahead.
The whole thing is that I do my active work. I make my calls to real estates and everything else. I also have a person who had helped me get my scholarship for school. They are also helping me from an outside. I got outside sources helping me looking for housing as well. But you have to do your work as well. I understand that. I've been doing my work. It's not about the system itself. It's about the housing situation itself and the price ranges on what they want to do.
Yeah. Yeah, it's very much about the system. And so, Chaplain, it sounds like, both you and Deborah are saying that it helps to sort of be a squeaky wheel who's willing to
Yes,
participate
it does.
and to be, that it's good to have workers and it's good to have support system, but you have to kind of try and help make that work for you. I'm just wondering if either of you or if anybody else has advice for somebody who maybe isn't a natural squeaky wheel, or whose life experiences have maybe taught them, more, different or sort of, lessons that make that harder to participate.
Yes. My thing is, I'm listening to the other two panels, and my given is that I've been in a program, and it's the only program I've ever been in, and I took transitional living into scatter site with a roommate, and then graduate, and I was listening to the other panels, and I was feeling like, wow, that's something that for me, if I had to experience it, yeah, I would know how rough it would be, because out there, housing is so expensive, and just for the person who is trying to even get a room, versus being in a program where you have the assistance and it continues to it continues to go on. You're not moving out of the program, you're moving into another site within a program. So I would say to those who are looking for places, they should find more they should find a more active role into looking into programs instead of just looking for living in a apartment in this, within it, without being in a program, because it would be more suitable,
Yeah, thanks,
Good advice
Scott.
right there.
Yeah, I mean, I think, I don't believe in one size fits all solutions, and I don't think supportive housing is the answer to, to absolutely every aspect of housing as it relates to people exiting homelessness. But I think if you're someone, like, who would benefit from services that are close by, it's a really amazing sort of model of care and living, to have everything be so co-located. Scott, could you just, since it was your first comment, could you just introduce yourself for a moment, and then Lockett, we'd love to hear from you as well.
Well, I'm Scott Burton. I've been with the Bridge program since '97. I've been through, the different channels, the transitional living, the scatter site with roommate. I did leave the program at one point in 2004 for personal reasons, and they actually took me back into the program, but I was put back into scatter site, and I wasn't able to go into graduate, because if I had stayed in the program, I would have been graduate. But it's been a safe haven for since my childhood. I mean, I was in special service schools. I was diagnosed with meningitis as a child. I had learning disability growing up. but I was out of a program in Virginia working in food service field. And so it was basically, I knew that I had an illness, but I didn't let it affect my ability to be a service to the working field. But when I got sick, I actually found myself coming back to New York, and this is where I'm at since that's happened. So that has been my story.
Guys, I'm Lockett, and my experiences with a lot of that is I never really lived per se on the street. Understand? I came from Texas to back here, and it was about hospitals, nursing homes, shelter. You understand? So I never really was in the street. But what I'm actually learning about the system itself, because separation between the elderly, such as I'm not that old, but you know, the elderly such as us, and the younger people that's actually homeless in shelters, I actually have to say, in my opinion, should not be. Where I came from on 30th Street to here, it was a person such as myself should not be in that shelter. Can't walk, can't move. You need medical attention, and there you would. But when they sent me here, I come to learn about this place. It's not just shelter; it's also here to help you medically. You understand what I mean? I don't understand how the apartment situation goes with the vouchers because I'm just learning. But I do believe that when they start looking for apartments for people, they need to take into consideration of people such as myself. I need certain things in the apartment that a lot of apartments don't have. Like I'm gonna call it handicap bathroom. I can't. Into helping you get apartments, then they really need to take a look at the individual and the individual. I don't see that. Hopefully, I need to understand exactly how it goes. And out of this, I can try to do. That's what I need to do on.
Excuse me, is it just me or is Mr. Lockett coming in chopped up?
No, Lockett, it was hard to hear the last part of that, of your comment.
Okay. It was chopped up, right? Okay.
Yeah.
Yeah, it's freezing.
Yeah. Lockett, try shutting your video off and maybe just do the audio. Yeah. Okay. Okay. How can somebody talk, who's been staying in a supportive housing environment, could somebody talk about the way that supportive housing has changed the way that they access healthcare? And if there's something that's going well or not well, we'd love to hear that as
well. Okay. January 21st, 2016 to November 1st, 2022. I was in supportive housing, Boston Road. Okay. When I first got there, it was like the Taj Mahal of the supportive housing, brand new spanking, brand new building, kept upkeep and whatnot. And it was like, I guess there was like a startup program there. And so everybody was like a guinea pig. It was like, everybody was a subject to their learning process. They encourage you to do what you're supposed to be doing. But as far as really like, you got some people that needs more attention than the others. Okay. And a lot of people need a lot more encouragement than the others. Initially, to be honest, I was one of them. I was one of those people. I just didn't give a damn. And I started finding myself falling apart. And so I found out, but I guess really it was through my own determination, to stop falling apart and follow up with my healthcare regimen, than so much as to the attention that was needed as far as them assisting me. Okay.
When you were making that change, what at the supportive housing site did you access?
No, listen, I was on the street for 5 years. I didn't do shelters. No.
Yeah, but once you like at Boston Road.
Oh, it was. Wait a minute. Initially, it was Common Ground. From Common Ground became Breaking Ground. Okay. And
I think the on-site services there are SUS.
Right. That's correct. Yeah. So, you don't get me wrong. You had a lot of great counselors or staff members there, and then you had a lot of people that left because it felt like they couldn't go no further. Like, I don't know. And it's between their co-workers as well as the residents that are disappointing to them.
Yeah.
But they, in some sense, they feebly, in a people sense, they throw out the availability to offer you to help yourself. But as far as them being more hands-on about it, not really.
Okay. What about others thank you, Daniel, others who are staying in supportive housing sites?
I am.
Go ahead.
Okay, what is the question?
How has being in a supportive housing building changed the way you access healthcare?
It hasn't really changed, because even when I was in the shelter, I always took care of myself. I did what I had to do. I saw my doctors regularly. I'd like to get regular checkups and stuff like that, especially because of all the stress and trauma that was going on from in the shelter. I feel I needed it, because I was like, one day I was reading a book and my hair started falling out, and that scared the hell out of me. I didn't know why this was happening. So I said, this must be a stress-related thing. You know what I'm saying? So I always took care of myself, even so now. I don't wait for my counselor. Matter of fact, when I have a meeting with my counselor, it's to tell her what's new on my program, what's followed up on, what's finished up, what I'm doing new. You see what I'm saying? I don't.
Yeah. So you're kind of quarterbacking everything and kind of letting the workers at the housing site kind of know what's going on.
I couldn't have said it better.
Yeah. Thanks, Chaplain.
Yeah.
Go ahead, Scott.
Yeah. I feel like with the supportive housing change, There's always been people just come and go. The staff, the turnover of staff is crazy. Because you get to know a staff member who's taking care of yourself, who's taking care of you, what your needs are, and you get used to this person, and then the next thing you know, oh, they're not here anymore, and then you have to start all over again with another person, and it gets to the point where it becomes, well, I'll be my own advocate. I don't want anybody to, so then you have to, so I had a hard time letting down my guard. I had a hard time giving up my way of doing things to another person who would say, okay, this is what I do, this is what I'm doing for you. And it just became like, I just wish it would be more of a time of a period for that person to be with you, not just like a couple of weeks or within a month or two, but, for a long haul, And another thing is for the staff to have a better understanding of what you're going through, you know, not everyone understands your mental health. They will band-aid it. Oh, you'll feel better. Take this medication. Or you take your medication. No, you're taking the medication, but it's not about the medication. You're upset because of what's going on in your family life or just a personal issue that is not pertaining to your mental health. It's right away. Oh, this person's not feeling. Um, and it's just they want to jump the gun, but they need more understanding. We're all different. We're not all the same with mental health. We have different issues, and that needs to be a very as mental health increases on people and programs and people are coming in here to work with people with mental health. They need more understanding. They need more of a background. They need more, enlightenment.
Yeah. So it sounds like so more time with staff members who have a better understanding of what people are going through and an ability to be sort of flexible and able to kind of tailor somebody's approach to their specific sort of set of circumstances. Yeah, that sounds wonderful. I want everyone to have that. I mean, I think what you described is kind of what, is exactly what we kind of hope and expect out of these kinds of services when we're setting them up. Can anyone kind of talk about specifically about sort of healthcare as kind of like one of those systems inside a supportive housing building or kind of inside of a shelter that they've experienced and the way that it kind of has or hasn't worked. And I'm kind of thinking both about accessing primary care and times you've just maybe needed, sort of one-off kind of visits to the healthcare system.
Well, okay. At Susan's place, they do have a clinic. And when I came into the clinic, I seen the PCP, which is the primary care physician. And it was all nice. They took testing, they did full blood count, everything else. But the thing about it is that it would help you get your medications and stuff. But on the other hand, as far as specialists and stuff, I ended up going to New York Presbyterian Methodist Hospital, which I was going to since I'm 3 years old and I'm 60. They have all the specialists there that I need: cardiologists, pulmonologists, hematologists, everything that I need there. So if there's an emergency and I'm at the facility, I can always go and see the doctor here. But other than that, I keep all my appointments at another location.
And just to like a quick follow-up, because I want to hear from everyone on this question, which is, does your caseworker like help you stay organized with the outside stuff, or is it something that you're doing entirely? And if they help you, like, have you like, it's like official, you've like filled out like medical releases of information and all that stuff?
I sign medical release information, but I do everything by myself. I'm very independent that way. I keep all my appointments. Matter of fact, I have an appointment on the 29th to see a physical therapy. Going today, I do the assessment and start doing physical therapy on my legs. This is all done by me. I feel that if you want to get somewhere and you want to take care of yourself, you need to step up to the plate.
You Lockett, you go ahead. I see you talking, but you're muted.
Okay.
Okay, we can hear you now.
As far as navigating through the medical, when I got here a year ago, they was navigating my medical. I was a little messed up. But I have situations like that in my life. You know what I mean? So coming here, they're doing something that I would do myself. Recommending you to the specialist, you know, all that kind of stuff. So what I've learned was they're doing, we already do can ourselves. Now they could be there for those who cannot, you know, that, but there's a lot of people who can manage that themselves. So a lot of that I just took and I keep up to date what I'm doing by being trying to help them. But a lot of it I actually do my I've been doing. I got into it.
Yeah, I mean, it sounds like this group in general is, or this group in general at this time right now is really on top of their own medical care in many ways, and sort of being kind of the driving forces behind that, which A, is wonderful, and B, as someone who has worked on the healthcare side in these settings, I will say that if everyone wanted to come and see the on-site provider, nothing would get done, and everybody would be very frustrated. Actually, one of the ways these programs sort of must work is to have a group of people who are capable of accessing services outside in order to kind of preserve the services on site for the people that really need it, who would have trouble doing that stuff kind of outside on their own. And so it kind of it's like a good thing, right? It kind of like helps everybody. But I'm curious.
You have to be.
Yeah, go ahead, Chuck.
No, you have to. It works best if you're self-sufficient and self-supporting. If you're waiting for someone else to give you something, it's not going to happen. Or very rarely will happen. Or may not happen when you need it. So you see what I'm saying? So you know you best. You take care of you.
Yeah. Scott or Daniel, you guys want to jump in on the tail end of this convo?
Well, sorry. What I could chime in to say is that, so you get a lot of people when they come into supportive housing, they used to that street living, this haphazard, they're not really into taking care of themselves. You know, it takes a minute to recondition yourself into a normal functioning life. But at the same token, you have members of the staff that's in the supportive housing. They, I can say, you got some that work to collect. I mean, they come there, they bring their presence to collect the check. Then you got those that really, they become overburdened because there are so many people that really want help, but they're limited into what help they can give. You understand me? Like they only versed in their training and offering you but so much. And then after a while, their knowledge, their sense of knowledge or whatnot is like gone because, you know, like Travis James, Mr. Burton, Ms. Lockett, and Ms. Deborah all said, listen, if you don't become the driving force yourself, you're not going to get anything. Okay? Nobody's going to say, oh, well, come on, reach down and grab you out of the crowd. You know, you gotta know what you need to do for yourself in order to survive. All right, so if you don't become the initiator of your own destiny and your own issue, I don't know what to tell you. You know, but being in supportive housing again, it does have its advantages because now you're no longer in the street. You have a little bit more private space isolation to have a lot more control of your life. You know, you can focus a lot better. But you know.
Thank you.
Well, all I can say is they're there when you need them. As far as way I've lived being in this program, but there are times where I did become my own advocate, and I did get the job done for myself. But it's very, you know, it's very difficult when you have someone who's supposed to be there for you, but they're not for you. They're not there for you. And you have to be like, okay, I can handle this. You know, I, I've been hit so many times off and on, and I've just been, you know, very fortunate, yeah, to have people around me that are there when I need them. And if they're not there, then I can go to another person. That's been my very much fortunate.
It is a true blessing to have a net when, you know, any one of us needs it, and to have people that we can rely on. I want to do a quick show of hands question before we move on to questions from the audience, which is, please raise your hand if your healthcare provider has ever asked you about your housing situation. Like if someone in like a medical office has ever asked, like in the encounter has asked you about your housing situation. Lucky I didn't hear that. Sorry, your audio is choppy again. One more time. Yeah, like somebody like in your primary care provider's office.
Okay, I have one.
Okay.
And that
Yeah, not that if they asked you like if to put your address on a form, but like, you know, if they asked you like what your housing situation is, just raise your hand and because there's been some questions from the audience that okay, so we got Lockett said yes. I saw Deborah's hand earlier.
Yes.
chaplain?
No, mine never did. Is
Never,
is
okay.
that a bad thing?
It's just a thing, you know.
I guess
I could make an argument that it's a bad thing, but I'm just
from
curious.
knowing,
I just want to have a sense of what, you know, what
no, from
people's
knowing
experiences
our
are.
relationship though, I would think he would think I live in regular house, regularly house.
And that might be really important to you or to somebody else, you know,
I never thought about that question.
yeah.
Hmm.
So it seems like, yeah, go ahead, Daniel.
I had a situation where they knew I was home. Okay. And I felt that I used to stay like when the weather was really, like raining or whatever, I would sleep on this church step. For some reason or another, that morning, instead of turning left, I turned right, and I came down and landed on my shoulder. Pain was so bad, I wound up going to the hospital. They come to find out I fractured my shoulder. You know, and now mind you, I wasn't even in a powered chair. I was in a manual wheelchair, bilateral amputee. You know what they gave me? A sling and put me out. You hear me?
Yeah, I hear you.
Now they knew I was homeless. Now what the
Yeah.
heck was I supposed to do?
Yeah,
I
it's
have
not
a friend
acceptable.
to this day. No, to this day now, this is as far as I can raise my. Okay, trust me. They knew I was homeless.
Yeah, it's not acceptable.
Yeah. It becomes like, you know, when I got off the street um and I went into, you know, the emergency, and I wasn't asked, was I homeless? I wasn't asked. I was just, you know, they didn't ask me any. It just was just so weird. It's like they didn't. It's like they didn't care to ask, you know. Uh, and I just told them. I just came out and just told them my whole situation, but nothing about being homeless. And then they took me in, and they found out later, you know, that that was the issue. But
Okay, so of the 5 panelists, 2 had been asked and 3 had not. So I think an important sort of consideration. Okay, so there have been a number of questions from the audience. So we're going to start with this one, which is, how can health professionals and their teams help you better or more? What specifically do you need to flourish?
It's a hard question because it would vary from person to person. But I would say if you show just more care, concern, and understanding, that would go a long way with helping the majority of people. Let them see that you really care and you're not just another number or just taking up space.
reading my paper. Yes. Yeah, I agree with him 100% on that. I think, you know, just to be more knowledgeable, be more compassionate, have more compassion about someone's situation, you know, don't just band-aid the situation, you know. I mean, it's when you have healthcare providers, provide help, you know. but provide help in a way where you're showing that, you know, you really take an interest in this person's whatever it is, you know. And I mean, I've been there. I've been there with people. I've been with good providers, and those who would just want to be there for the hours. Okay, I can't wait till my shift's up. What do you need? You know. So yeah, that's fine.
I have to piggyback on that. The other thing is that if they were to do a better examination on patients, rather than just sit them down, talk to them, and send them out with prescriptions of medications, I think that would really help a lot. Do more of a thorough examination and listen to what they have to say, rather than just pat them on the back and give it's like giving a dog a bone and send him on his way. That's what they're doing with us.
You know, I find it rather confusing because, like, see, when I was homeless, the quality and attention and care that I got as comparison to now. Now, listen, there were times, I mean, I was legitimately really sick and I should have been hospitalized. But they felt as though they were going to hospitalize, they would be giving me a bed and some meals. Okay, rather than addressing the present issues. Like, quickly as an example, I was so sick, I wound up going into a coma from pneumonia. Okay, and then, you know, they really was going to get rid of me until until I was just out of it. I woke up a few days later, but now I'm not homeless, and they trying to look around. They trying to keep me. I'm like, oh hell no, let me go. But you know, I'm the same person facing some of the same illnesses. But before, you wanted to kick me back out in the street. Now it is. I'm trying to get the hell out of there. Don't hold me. Let me go home. You know, it's the difference of the quality of care that you get being homeless as opposed to being, you know, stabilized living somewhere. There's more humane treatment.
Lockett, you're muted. Wait, Lockett. Oh, yeah, go ahead. Yes.
The question that you asked about what can they do to improve? My thing is, and I really like to say this, it don't take much, man. Genuinely care about the thing, and make, you know, like, you're not there just for a paycheck, man. You want to really go into the healthcare thing and help somebody, then help them. Even if it's just to show them that you're there. If you can't do nothing but just be there, that goes a long way. And I believe you start there, but I get it.
Yeah. I mean, it's really, I think it's really noticeable how aligned everybody's comments are. That what people want is from their healthcare professionals is not just for them to be compassionate, because of course they should be, but that they should also be able to demonstrate that, and that they should be, that the thing that they're doing is there's a disconnect between whatever care and compassion they might feel internally and the way that that's being perceived by someone that's getting taken there, by someone who's getting taken care of. And I just want to highlight, Deborah mentioned specifically kind of physical exam stuff, and I think the physical exam is this really, I mean, I think there's something really special about, I'm biased because I'm a doctor, but I think there's something really special about the interaction between medical providers and patients. It's such a such a unique interaction, and it's such an opportunity to try and get a lot of stuff really right in a really short period of time. It's not always easy to do, but I think the physical exam is this really underused way to establish connection. It's also really risky because you have to be really vulnerable as a patient to let somebody physically examine you, to expose your body, you know, whether it's in a quiet private exam room or in a crowded emergency room, or, you know, or whatever it might be. You know, it's not something to be taken lightly. We've got about 2 minutes left, so I think we're gonna just wrap it up. If people want to have like a, you know, sort of final, you know, 20 seconds, but I just wanted to say thank you to our panelists for taking the time and being candid with your answers. Thank you to everyone for tuning in. Thank you to the Health and Housing Lab for organizing all of us.
Thank you for having me. I appreciate it very much. And like I said, once again, I just want to thank the person who's responsible for helping me in Susan's place, which is Miss Evelyn Turner, who is the Director of Social Services. She's bringing programs in, and the program that helped me get back to school is really helping me out. So with that, I really thank you for letting me be in on this.
It's wonderful. And
Try to do the people questions.
sorry, say that again, Chaplain.
The audience. I thought we were gonna do questions and answer with the audience.
That last question was from the audience.
Oh, excuse me.
Sorry.
Listen, this has been a very entertaining and knowledgeable experience to share with all my other fellow panelists. Ms. Ingrid, I thank you very much for inviting me. And this has been a very, very warm experience. And thank each and every one of you for allowing me to share your time and your space. Thank you.
Yes, I want to say it's been a pleasure meeting you guys. Your stories have really inspired me to take care of myself better, and to say that I wish you all to stay healthy and take care of yourself. And it was just a pleasure being here. Thank you all.
Sorry, Lockett, we can't hear you. I don't think we can still hear you.
I don't understand why.
Okay, we can hear you now.
Have me on your.
Thank you. All right, well, I'd like to thank all of our amazing panelists and our moderator for making this event possible. I'd also like to thank the Health by Housing Lab team, the Health and Housing Consortium team, and the Corporation for Supportive Housing. Thank you everyone for joining.